I'm very excited to introduce my next guest of today. Dr. Giada Sebastiani is an associate professor at McGill University. Her training and involvement in the liver community span across the nation and the world. She has many accomplishments and won many awards. One of her work focus is fatty liver disease. She is a founding and steering committee member of the Canadian NASH Network and panel member in the Consensus on Models of Care in Non-Alcoholic Fatty Liver Disease of the International Liver Foundation. Today, Dr. Sebastiani will be talking about the hidden risk of fatty liver from diabetes. Please join me in welcoming Dr. Giada Sebastiani and our host, Valeria Zaborska.
Well, thank you for joining us, Dr. Sebastiani. It's a pleasure to have you here. So for our first question, according to Diabetes Canada, in a report done in 2020, roughly 11 million Canadians are currently living with diabetes or pre-diabetes. Can you please tell us a little bit about the connection between diabetes and fatty liver disease and what the odds are of developing fatty liver if you are someone who has diabetes?
Well, thank you first for the invitation. It's a real pleasure to be with you, Valerie, and with our patients and with our community. So it's always important to discuss any concern, any question that our patients can have specifically on this very frequent liver disease. So to answer your first question, type 2 diabetes is for sure one of the main risk factors for non-alcoholic fatty liver disease. And the prevalence of fatty liver disease, in fact, in the general population in Canada is 25%. But if we speak about patients living with diabetes, type 2 diabetes, this prevalence increases to 50 to 80%. This means that patients with type 2 diabetes have an odds of 2-3 times higher than the general Canadian population to have fatty liver disease. If we translate this to the numbers in Canada that you just mentioned, it would result in 5 to 7 million of Canadians living with type 2 diabetes also having non-alcoholic fatty liver disease. This association between type 2 diabetes and fatty liver disease is so tight that we actually call it bidirectional association, meaning that persons with diabetes have a high risk of developing fatty liver disease. And on the other hand, patients with fatty liver disease have also higher risk of developing diabetes. It is like a dog that's chasing its tail, or really a true vicious circle. Studies show that patients with type 2 diabetes, for example, are less likely to respond well to their anti-diabetic medications if they have fatty liver disease, while improvement of fatty liver is associated with remission of type 2 diabetes. On the other hand, type 2 diabetes is the most important risk factor, not just for fatty liver, but also for the scarring of the liver, which we call fibrosis, and it is associated with fatty liver. Liver scarring or fibrosis is what will lead to the development of liver cirrhosis, which is the end-stage liver disease highly associated with premature death, liver cancer, and need for liver transplantation. So we can say, again, that while the prevalence of scarring fibrosis is about 2 to 4% in the general population with the people with fatty liver disease, this can be as high as 18 to 20% in patients with type 2 diabetes, which is about 4 to 5 times higher. So again, type 2 diabetes and fatty liver disease are very closely linked.
So you mentioned type 2 diabetes frequently in the association. What about other types of diabetes, such as type 1 that you can get from a younger age, or gestational diabetes that pregnant women can get? Are they similarly associated or less so?
So this is actually an excellent question. Type 2 diabetes remains the main risk factor for both non-alcoholic fatty liver disease and associated liver fibrosis scarring that we mentioned before. But type 1 diabetes also carries an inherent risk for non-alcoholic fatty liver disease. In several studies, the prevalence of fatty liver disease in type 1 diabetes ranges between 20 and 27%. And this depends also on the type of diagnostic tool that has been used to do the diagnosis, like ultrasound or biopsy. this figure, it's relatively high if we consider that many of patients with the type 1 diabetes are relatively younger than patients with type 2 diabetes. As for the gestational diabetes, this is also a very interesting actually question, because the prevalence of fatty liver disease is also significantly higher in women with prior gestational diabetes, with an odds of about 2 times higher compared to the general population. So the conclusion is, yes, there is an association also with other types of diabetes, but type 2 diabetes remains the main risk factor for non-alcoholic fatty liver disease.
Great, thank you. So in terms of the association between fatty liver disease and diabetes, you were mentioning it's bidirectional. So how does fatty liver disease affect blood sugars and affect diabetes? So I understand this might be complicated pathophysiology, but if you can maybe summarize.
Oh, well, absolutely. So, non-alcoholic fatty liver disease and diabetes are very closely associated. The fact is that the main actor in play in the pathogenesis, basically in causing the fatty liver disease, is insulin resistance. And insulin resistance is very much an entity frequent in patients with type 2 diabetes. So the close link between non-alcoholic fatty liver disease and diabetes is mostly coming from insulin resistance.
Okay, great. So we've talked about fatty liver disease a lot. Do you mind telling us what is fatty liver disease and what is the difference between non-alcoholic fatty liver disease and NASH, which you mentioned, or non-alcoholic steatohepatitis?
Sure, Valerie. So, non-alcoholic fatty liver disease, when we speak about it, we speak about an umbrella term, we also say in scientific terms. Non-alcoholic fatty liver disease encompasses two main entities, which is non-alcoholic fatty liver, so it's simple fat, basically, and NASH, which is characterized by both fatty liver and inflammation. To define a non-alcoholic fatty liver disease, the definition is a fatty overload of more than 5% of liver weight in absence of significant alcohol intake. This is very important to underline, because many times patients come to the clinics, of course, and say, I don't drink alcohol. How it is possible I got fatty liver? This is a metabolic fatty liver. It has nothing to do with the alcohol, which can also cause fatty liver. So that's why it's called non-alcoholic fatty liver disease. And the main causes of both NAFLD, non-alcoholic fatty liver disease, so even the simple steatosis, fat, and NASH, are indeed metabolic conditions. We already mentioned type 2 diabetes, but for sure also obesity. Elevated cholesterol and hypertension are also important risk factors for non-alcoholic fatty liver disease. It has to be said that NASH represents around 20 to 30% of the total cases of non-alcoholic fatty liver disease. Besides metabolic risk factors that we just mentioned, there are many other important risk factors. It's called a multifactorial disease, non-alcoholic fatty liver disease. These include, for example, life habits. These are essential in the pathogenesis of non-alcoholic fatty liver disease. Sedentary lifestyle, snacking, fast food, diet rich in saturated and trans fat, processed and red meat, and food and beverages added in fructose are deleterious and detrimental for the pathogenesis of this entity. There is also some genetics behind fatty liver disease. For example, Hispanic ethnicity and people from South Asia are at higher risk for fatty liver and NASH, and also for liver fibrosis and scarring related to NASH. And there is also some evidence that alteration in the gut microbiota, which are the good bacteria living in our intestine, can be also associated with fatty liver.
Wow, thank you. So this is a question from an audience member who asks, I am very skinny. Can I still develop fatty liver, and how does that happen?
Absolutely. This is also a very good question because skinny persons can indeed develop fatty liver. This is a relatively more recent entity that we call lean NAFLD, lean non-alcoholic fatty liver disease. About 7 to 20% of patients with non-alcoholic fatty liver disease are skinny, lean. And this is why we call lean non-alcoholic fatty liver disease. It is thought that these patients may still have some metabolic imbalance. We spoke before about insulin resistance, for example, maybe some subclinical form of insulin resistance, and also a diet rich in the some elements that we spoke before, fructose, for example, or cholesterol, can be responsible for lean NAFLD, lean non-alcoholic fatty liver disease. Unfortunately, also lean non-alcoholic fatty liver disease can lead to scarring, liver cirrhosis, and related complications. So this is still an entity, a clinical entity that should be taken in consideration.
Thank you. So in terms of having fatty liver disease, are there any signs or symptoms to watch for? And if not, how is it usually diagnosed? Are there tests, imaging, and how do we know?
Yes, the problem with this disease is that we call it a silent killer. I know it's a very scary term to hear, but this is actually the title of the International NASH Day that it's yearly held in June. So the first one was held in 2018 actually, and it was really called NASH, a silent killer. Because unfortunately, NAFLD and even NASH, so the more inflammatory form of fatty liver disease, doesn't give specific signs or symptoms until there is already cirrhosis or even liver cancer. For example, several studies showed that up to 80% of patients with non-alcoholic fatty liver disease can have normal liver transaminases, the test that we usually check to see if there is inflammation in the liver. And 20% of patients with scarring, with fibrosis, can also have completely normal liver transaminases. So this is not always the right thing to do if you want to make sure that the patient doesn't have fibrosis or non-alcoholic fatty liver disease. For this reason, it is essential to be aware about the existence of this very frequent liver disease, particularly for patients with type 2 diabetes or obesity. For example, recently in 2019, the guidelines from the American Diabetes Association and also some liver associations have recommended to look for liver fibrosis due to fatty liver in patients with type 2 diabetes. For example, to do ultrasound or to do some serum fibrosis biomarkers are called. It's just a simple test, blood test, where some of the tests that are usually done by the endocrinologist or the internal medicine physician or the family doctor can be computed to see if a patient can be excluded for fibrosis or for advanced scarring. And after that, there are other tests, always non-invasive at first, of course, like, for example, the FibroScan or shear wave elastography. These are ultrasonographic tools, advanced, that can see the stiffness of the liver as a surrogate for fibrosis. Only as a third line test, we use liver biopsy in those patients in which these non-invasive tests have done, for example, have given discordant results.
Sorry, thank you. So in terms of patients who have type 2 diabetes or fatty liver, since it's bidirectional, by treating one of the diseases, can you reduce your risk of developing the other or reduce bad outcomes or severity of the other? So for example, if you're taking metformin for diabetes, is that safe for the liver, and will it reduce your risk of developing fatty liver?
Absolutely. This is the answer to this question is yes. It's very important to always consider the very close association between type 2 diabetes and fatty liver. So how we can take care of the liver, and on the other side, how the liver can take care of the diabetes. We mentioned before that if the fatty liver improves, also the response to anti-diabetic medications actually can improve. There are several recent studies to prove that. I think the most important thing for patients living type 2 diabetes is, the first thing I always say is awareness. So to be aware of this condition, that it's very frequent in people living with type 2 diabetes, and to know about what I call the winning trio, or the three musketeers, know about fatty liver and talk about fatty liver with their doctor, with their physician, and maybe do a test, as some guidelines recommend, to see if there is fibrosis. Eat well, and the Canadian nutrition guidelines, for example, are excellent in this sense, and they're very good also for fatty liver, what the Canadian nutrition guidelines mention, and the regular exercise. This is really a trio, a combination that is excellent. In terms of the medications that are used to treat diabetes, metformin is safe for the liver. It's not a medication that has proven to specifically be a treatment for fatty liver disease. But for example, there are some recent evidences, not yet confirmed, that metformin could maybe reduce the risk for liver cancer in patients with type 2 diabetes, but other studies are needed for sure. There are other medications that are used in type 2 diabetes already, like GLP-1 agonists, for example, that have like a positive side effect. It's a positive side effect, weight loss. And weight loss, it's the most important and still the first line treatment for patients with fatty liver disease. So really, the weight loss can improve not only fatty liver, but also fibrosis, even the scarring. So this medication, although they have not been yet proven efficient completely for the fatty liver, they can improve also the fatty liver as a positive effect when the diabetes is well controlled. Overall, I think that when the diabetes is well controlled and there is a good management of lifestyle, of the weight loss, this is really essential also for as a treatment for fatty liver disease.
Great. And what about for diabetes patients who are on insulin? Is insulin safe for the liver?
Yes, insulin is safe for the liver. There is no study that has shown that insulin shouldn't be used in patients with fatty liver disease. There are maybe just some pathogenetic evidences which have yet to be confirmed, that if there are significant oscillations in the levels of insulin, then this can maybe also affect the liver, but as of now, insulin should be used, and I think we refer especially in type 1 diabetes, of course, that are very much dependent on insulin. So it should be used and should continue to be used.
Okay, thank you. So you mentioned that some of the best ways to treat fatty liver currently are exercise, eating healthy, losing weight. Are there any drugs on the market or close to being on the market for treatment of fatty liver?
Yes, that's a very good question as well. So there are two drugs that are already recommended by the guidelines for the treatment and the management of non-alcoholic fatty liver disease. One is vitamin E, which is an antioxidant, and the second is pioglitazone, which is already a drug which is used as a treatment for diabetes. None of the two have shown significant improvement in fibrosis, in scarring, but both of them have shown reduction in transaminases and reduction in inflammation in the liver, so reduction in NASH. However, these are medications that should be used in patients with a biopsy-proven NASH. So this is very important. In terms of the future looks bright. There are many global clinical trials ongoing which are studying other medications, antifibrotic medications, so medications to reduce the scarring into the liver. There are two molecules that are already pretty advanced in the phase 3 studies, but we need more time to have the complete results. And I wish to underline that even if we will have even better drugs to treat fatty liver, and especially fibrosis, scarring, this has always to be associated with lifestyle modifications. That's really essential. The combination of regular physical exercise and diet are the most powerful weapon in our hand for now against fatty liver disease. So this is really very important to always think about a combination of lifestyle modification and, in case it is needed, a drug.
So speaking of diet, would you recommend a diabetes diet for patients with fatty liver disease, or is there another diet plan that you would say is the best to tackle both?
Yes, that's also an excellent question. I'm very excited about these questions that are they're touching the main important points actually of this disease. So according to all the liver guidelines, they mention a combination of weight loss achieved with diet and regular exercise, which is the way to go, as we said before. In terms of which diet, first, it is to be said that many studies have shown that the diet and the exercise have to target specifically a reduction of body weight 7 to 10% in order to achieve a regression of fibrosis and NASH. So this is the target, at least 7 to 10% of the weight of the to lose or in terms of body weight. And what is very interesting is that several studies have shown that improvement in fatty liver disease is associated with the use of Mediterranean diet. The Mediterranean diet is characterized by daily servings of whole grains, legumes, nuts, vegetables, fruits, and olive oil, several weekly servings of fish, moderate weekly portions of dairy products, cheeses, poultry, and eggs, and only really in special occasions the use of meat and sweets. So this is the classical Mediterranean diet. And one thing that I want to add to this is that water must always be the drink of choice, while it is absolutely essential to avoid food and drinks rich in added fructose like sodas, which are absolutely detrimental. We already mentioned this, but I want to still to underline, as well as red and processed meat. So the Mediterranean diet actually could be adapted to all the other cultures if you think carefully. In fact, the Canada Food Guide is very similar to the Mediterranean diet. But one important component is the extra virgin olive oil, because it's rich in beneficial polyphenols. And if this cannot be used, canola oil can be also a substitute instead of butter. It doesn't have the same polyphenols as extra virgin olive oil, but it's a good substitute. In terms of your question on the diabetic diet, absolutely. The diabetic diet is actually very similar to Mediterranean diet if we think together about this. It recommends healthy carbohydrates such as fruits, vegetables, whole grains, legumes, low-fat dairy products. It also recommends dietary fibers like vegetables, fruits, and nuts, same products in the Mediterranean diet, and also healthy fish, at least twice weekly, like salmon, tuna, and sardines, and good fats such as avocados, nuts, and olive or canola oil. So it's actually relatively similar. So I think both of them, the Mediterranean diet and the diabetic diet, are absolutely excellent for the fatty liver. Always remember, this is also nicely underlined by the diabetic diet guidelines, that absolutely to avoid any foods or drinks with added fats, sugars, and sodium. So, for example, avoid butter, beef, hot dogs, sausage, bacon, and limit processed nuts, baked goods, shortening, and stick margarines. So they're very similar, actually, the two diets.
Great, thank you. So for our last question, one that's very relevant to the current time, would you recommend the COVID vaccine to your patients who have both diabetes and liver disease?
I surely recommend it. There is a recent position paper from the European Association for the Study of the Liver about the use of COVID-19 vaccines in patients with chronic liver disease. These guidelines recommend vaccination against COVID-19 in patients with chronic liver disease. And of course, also non-alcoholic fatty liver disease is a chronic liver disease, hepatobiliary cancer or liver transplantation recipients. These guidelines, this position statement also stated that the vaccination should be prioritized in patients with cirrhosis and in patients with liver disease and risk factors for severe COVID-19. We know that type 2 diabetes and obesity are among those risk factors for severe COVID-19 infection. So that's why it's important to absolutely to recommend the COVID-19 vaccination in this specific patient population. In terms of side effects, side effects are rare, are very rare actually, severe side effects from the COVID-19 vaccines. The regular side effects that one can be expected are fever, fatigue, headache, muscle pain, chills, diarrhea, pain at the injection site, but usually they resolve within 48 hours. And the last thing I want to mention is that, as I said, severe side effects of COVID-19 vaccines are extremely rare. And if we think about the risk of thrombosis, for example, with the AstraZeneca vaccine, is 0.0004%, while the risk of thrombosis with COVID-19 infection is 16%. This means that the risk of having thrombosis from the vaccine is 41,000 times less than the risk of thrombosis from the virus.
Well, thank you so much for your time, Dr. Sebastiani. It was a pleasure to have you. And enjoy the rest of your day. Thank you.
Bye-bye.